you, Kamunyendo, our CS national government, teacher, the administration of both in facilities and in public facilities. We have gone ahead to organize the CHPs as our first line of health prevention. And these HPs have all been given kits, and now they are undergoing training so that they basically become useful in prevention of disease in the community. Now, in terms of stipends of CHPs, we have also done a level best at the county level to pay them, and MCS, we are patiently waiting for the many have from the national government. I'm sure, as you talked to us today, is delivering some very good news to us. To add on that, Madam CS, we know very well that the policy is on PCNs, that's the primary care networks, and I'm happy to inform you that as a county, Kakamega has already formed 12 PCNs, and where we stand right now in Mumias West sub-county, we do have one PCN that is already working, where the hub is our county, sub-county level 4. That's not very far away from here. I'm delighted to inform you that county has a population of about 100 to 150,000 people. And therefore, as per the criteria of formation of PCNs, one PCN is enough to cover this population. I know as we are here, we are collaborating with the St. Mary's Hospital in terms of referral systems, in terms of sharing personnel, and in terms of even outreaches, because people being served are the same. And as we move forward, we want to have that bond between the private and the public sector very well in such a way that our people, whether they're getting services from the private or getting from the public, they should get quality health services. As I said earlier, this is community as manifesto. So you are coming quite steadily, basically to highlight many of these issues that we are now undertaking as per the new health policy in terms of prevention. We have also, on top of that, we have also registered all the CHPs, and through the efforts of the governor, the CHPs are going to be registered for NHIF. All of them in Kakamega County, who are about 4,250. All of them, they already, governors already put money aside. All of them will be put on NHIF. And that is something that's going to really help our facilities in terms of our own revenue collection, which I know is very high on the agenda of the President and also even the governor. With those few remarks, may I now ask all of us to stand. Welcome our very own of health, and she's also from this region, and she has visited us. Don't see us from nature. Welcome at home.
Thank you very much. Can we have our seats? Thank you. Thank you, county team, the sub-county team, sister and father, the management of the St. Mary's Mission Hospital. Good afternoon.
Good afternoon.
I am very pleased to be here this afternoon. And let me start by passing our apology. We ought to have been here much earlier, but because of the expediency of work, wherever we have been, there is quite a lot of work in this year. We got delayed there by work. But we are happy to say better late than never. We almost wanted to change and say we'll come another day. But I was told people have been waiting. So I said, no, let's just go and see what we can. So I'm indeed very happy to be here today. And this is part of my routine visits to the counties. We have gone ahead with the rollout of universal health coverage. And so we have to be on the ground to see as we roll out in Nairobi, what is happening on the ground. I can sit in Nairobi assuming that UHC is all going everywhere and maybe for ground mambo difficult. I prefer to see for myself, and that's why I'm here at this counties so that we can get to discuss. Happy since you have talked about the CHP program, that's the foundation of UHC, those CHPs. And from where I sit, we are in a good space. We have made a good foundation. Not saying how we should move forward. I hope you have printed the forms as well.
Yes.
From this year. And when I said you have received the forms, they made noise and said no. So I hope yours, when I ask outside, they say yes.
Yes.
Good. So if that has been received, then we have laid the foundation. About the stipend, national government has been ready for a very long time. In fact, this January, we got the exchequer of 1 billion for all the CHPs. So now it's just for the COG to put their money into, we agreed on one account. Because you see, a CHP cannot get 2 stipends. They just need to get 1 stipend of the 5,000 shillings. So now 500 for NHI. But even as we inform NHI, now we take 300. So that then they are left with 4,700. But in the last summit with governors, we agreed that it is going to come from 1 pot. So our money is already in the pot. We are waiting for the governors to put in the pot, then we start paying out. So that should not be a problem. The other reason why I'm paying my visit is that once as you lay the foundation, you start moving upwards. So we have done the CHP program. Now is to see how ready is able to and everything to provide services. Most of my visits are going to the lower level of facilities just to see how ready are they to provide services. Before we close for Christmas, we launched the level of service facility assessment report. It was not a good report. Only 17% of health facilities in this country are always ready to serve a patient when the patient arrives. You can imagine out of the 14,000 facilities in the whole country, only 17%. That means in most health facilities we go, they are not ready to receive a patient. They'll be missing 1 or 2 days. But the most important thing that we have to ensure that our facilities have is a health worker and supplies. Those two. And those are the things that actually make people move from one facility to the other. Those are the 2 issues that make people to leave the low level facilities and go and congest higher level facilities. So if we want to decongest higher level facilities, then we have to make sure that the low level facilities are well prepared. So I will be making stops in the dispensaries around just to check do they have the drugs, are the health workers there or not. And I'm not doing that because I doubt the capacity of governors to do this. I'm doing it because Mwananchi ni mmoja. There is no national government, Mwananchi, and county government. If I come, it is just a check so that then once we identify the gaps, together we see how we find a solution. The reason why I have chosen this mission hospital because I know it plays a key role in the community around me. And since you have right is that we are putting facilities in the primary care networks. And in a primary care network, it is all facilities, whether they are public, they are faith-based, or they are private. They all have to belong to a primary care network. And I want to encourage you as well that if you have a faith-based facility like this one, it can equally be a hub for your other facilities. It does not have to be a public hospital for it to be a hub in the primary care network. If you have a well-equipped faith-based facility or a private facility which is able to work together in a primary care network, we make it a hub so that it can be supported other facilities. I'm here also to hear from the hospital how can we be of support to you to ensure that you are providing services to patients. Wherever I have been, they are crying about payments from NHIF. At least I haven't had that from you. I think it is because I haven't had that from you. I ought to believe you don't have that problem. Do we owe you? We do. How much money? 70 million. That's a lot of money. Which are genuine claims. Yes. Not fraudulent. Because the other problem that I'm fighting with is fraudulent claims from facilities. Sister, there are hospitals outside here that have amputated a left leg of a patient 3 times at the knee. Is it possible? It's not. Yeah. So with such kind of claims, then they cost, I believe, even for genuine claims from facilities like here. But the last I checked, we had talked with the bishop. We were with him in Trans for mass there. It's about 3 weeks ago. And I ensured that a payment of 8 million was done. Did you receive it? You received it. Now we're in the process. I think we have processed another 13 million. Have you received it? You have received. You can at least clap for me. After previously for you to get 5 million, it was a headache. But now, within a month, you have received 8 million, you have received 13 million. So the remaining one is for us to do reconciliation. If it is payable, we will not have a problem paying it. Because I am convinced they are not part of the problem that we have with fraud. Yes, I'm very convinced that they are not. So it's for us that to do the reconciliation and whatever is outstanding, then we should be able to assist each other. In some places we have issues of equipment, and I think we want to come from you to say how we get to support and provide services. But I'm not very far from it. This is my home. Yeah. So if health has to work anywhere in this country, it has to be in Western. Yes. Yes, you must be the role models of the rest. So should you have any issue, please feel free to let me know where we can collaborate, where we can work together and see how we can support our people. And I also want to thank you because I know they provide services at very, very, very subsidized fee. If not free, I'm sure you only put some small operational expenses, which is a people are poor. Our community in Western people are poor. Getting food is a problem. So you can imagine healthcare. It is not even a priority for them. They would rather die at home. In Trans I did a medical camp, and we got how many people? 11,000 people came for the medical camp. 11,000. That tells you that people in this home are unwell. But because they have no resources, then they don't want to. And what that does, it strains the health system because they will now come at a point when they are critically ill. Yet it is something that we would have managed if it had been discovered earlier. So I want to thank you for the service that you continue to provide. Let us just work together and see how is it then that you are going to leverage and maximize and optimize how we pay for government, be it on human resource, be it on supplies, and now that we want to put in a network, a digital system, then you should be able to benefit like every capacity that is there being like a public facility should be able to benefit. The changes that we are doing in NHI is because of the support of only 3 million Kenyans are on payroll. What about 7 million? We have to find a way of taking care of the healthcare and the opportunity to access such facilities. So we work together to see how we can provide services to you. Asante sana. Thank you.
Sister, on behalf of the
hospital, and then we will take a brief hospital tour, and then CS together with the team, research, with a desk, media, together with members of the public, partners. So, welcome.
God is good.
All the time.
All the time.
God is good and that is it.
Happy New Year to you all.
Happy New Year.
So I stand here full of joy to receive our CS in our midst, to visit us and talk to us. It's a pleasure to us to host and here. So I'll just give a brief overview of our facility. This is St. Mary's Mission Hospital, Mumias, 1932, by the first missionaries who came along, the Muslim sisters. So when they left, they handed the facility back to the Diocese of Kakamega under the leadership of the Right Reverend Bishop Joseph Obani, who is not here with us, but Father is representing here. So the hospital serves a catchment area of population of 6,956. It also serves as a referral facility to 33 health facilities within the catchment area. Being a level 4B teaching and referral hospital, it has a bed capacity of 255. We offer almost all services, both outpatient and inpatient. And the services are offered 24/7 to our clients. Just to mention them, we have the specialized clinics, maternity, laboratory services, mother and child services, pharmacy, children home services, imaging services, theater, renal, physiotherapy, comprehensive care clinic services, community-based health care, and ambulance services. We also offer specialized clinics, that's the dental, obstetric, MOPC, pediatric, eye, ENT, SOPC, dermatology, epileptic, and orthopedic clinics. The maternity is our strength in this area and in this hospital, because like last year we had a total admission of 3,653. We had total deliveries of 2,964. Live births were 2,991. Babies discharged alive were 2,945. Neonatal deaths we had 44. Maternal deaths we had 3. Preterm babies we had 330. And then KMC we had 189. So we have a resident gynecologist who supports us very well in this hospital, and that's why we managed to avoid maternal deaths in this hospital. Because mothers start their journey early, they come in good time, they pick up, they are followed up by our medical team until they reach the time of delivery. So with that, we feel that's where our strength is. We don't let mothers go, and even when we tell them we are full, they still opt to remain here. And as we shall be going around, you will see that sometimes we put mothers in between the corridors because they don't want to go elsewhere. They feel at home here. Opportunities or areas of partnerships. This hospital has a vast space. We have a lot of space around, which is not well utilized. We have rooms that are not utilized well because of financial constraints. We have enough space for further development. That's the space or room for a CT scan machine, which is to be installed, but because of funds, we are not able to put it up or to have it operational. We also have an ICU room with beds, but we lack oxygen plant, piping, necessary equipment, and human resource to enable it to be functional. This will also, if this can be functional, it will support the county referral hospital by minimizing the number of referral cases to them. Then the hospital has a renal unit in place, which is supporting greatly the county referral hospital in the care provision. There's also space where we could have a modern comprehensive maternity complex, since our data has proven our excellence in the maternal care service provision. Most of our buildings are old, as you heard that we started in 1932. And most of these buildings started way back there. So if we could get a way of having a modern facility of infrastructure to enable us serve our citizens around and even beyond, it would serve the purpose of us being here. Then we have NHIF capitated clients. We have national scheme 21,649. UHC, we have the 307. Older persons with severe disability, we have 54. The health insurance for subsidy program, we have 370. County government of Kakamega, we have 1,345. Then registered Mama, we have 1,779. All these patients or clients are registered here, and they come here for their medication and their health services. The challenges we have as a facility, we have delays in NHIF disbursements, which makes us not to be able to carry out our activities as expected or planned. Lack of necessary equipment and machines, that's the ICU, CT scan, and theater machines, which also makes us to lose patients sometimes, because as we are preparing the patient, maybe the patient will not be able to move or to be moved to the next facility. Then we find the patient dying on the way. But if we had this ICU operational, the CT scan operational, then we can have our patients taken care of well. We have poor infrastructure as the buildings are old, and the security of the hospital is also not good. As you came in, you saw our hospital, how it is just open. So sometimes we get, when there's a problem, we find people coming in, marching in, and very rough to cause chaos around. So it also creates a problem to our health care providers. Then we have high staff turnover due to delays in salary payment. As 95% of our clients are NHIF members. So you find that when the payments delay, then that means also salaries will delay, and also service delivery may also be compromised. Because if someone is not paid and he has to offer, he or she has to offer the services, it's not motivated at all. Then we have frequent stockouts, especially in medical supplies like drugs. Sometimes when we are not paid in time, that means we shall be sending a patient who are buying this medicine, don't have it, which also creates another problem. We have an NBU, which has not been equipped with the necessary machines, like the resuscitators, incubators, and the CPAP machines. The bed capacity for the NBU here is 25, the coach capacity, the court capacity 25. So we receive babies from around us, and even as far as Busia, Bungoma, being brought here. And because of lack of those machines, we find that sometimes we are not able to handle them. Then there's also the discontinuation of staff secondment from the government to our facility. Sometimes we had staffs who were seconded here by the government, and it was uplifting us when it came to payment of salaries paid by the county or the government. But when they were removed, we remained with our own, so we have to struggle to encourage them. Then our guiding principle and motto, principally the hospital seeks to exemplify Christ in its in the healing ministry. So as we work here, we emulate Christ, who is the great teacher and also the great healer here in the hospital. And our motto is we treat with care and God heals. That's the philosophical guiding belief that and the hope enshrined in its offerings and daily practices. I've mentioned about the teaching. We have a medical training college with us around, and we have the principal here with us. Maybe if she could just share something on for her what is offered. Thank you, and may you be blessed.
So good evening, everyone. Good evening. My name is Janet Nando. I'm the basic to the administrator. Everyone, welcome to St. Mary's Fraternity. The hospital is attached to St. Mary's Medical Training College, which is formerly known as School of Clinical Medicine. Due to the diversification, it became a medical training college. We offer 3 courses at the moment. Our core course was Diploma in Clinical Medicine and Surgery that started 30 years ago in 1994. Later on, with the transition and diversification, we have introduced 2 others. In view of UHC, we have Diploma in Community Health and Development, and we have Diploma in Perioperative Theatre Technologies with the support of TVET. We offer services, training services to both male and female students, and it's both boarding and schooling. Being a Catholic-sponsored institution, we value spirituality, and you will realize that once the healthcare workers are trained from the beginning on the ethics and the professionalism, they carry it forward into their duties. So we appreciate that, and we appreciate the Catholic Diocese of Kakamega. The staffs are dedicated and experienced, and the students not only do their training at the school, they also come for the practicals at the skills lab and at the hospital. Our graduates are employed, most of them at Kakamega County. They work at the country and even beyond Africa and further on. We have a few challenges, however, we would like to expand our learning and training infrastructure, and we just have an appeal that maybe this is not the appropriate, but being a medical college, we cut across the health sector and the education sector. We would like the government to consider the private institutions in matters health. You realize that the private institutions have been left out. Previously, we were included when Afya Elimu was in place, but please consider us when we review, when you're doing the monitoring and evaluation, please consider the private institutions, because not everyone will be absorbed in KMTC. They have their challenge of the numbers, so some will, because of they are not able to go to KMTC, they'll opt for the private institutions, not because that they are actually able to pay their fees. So kindly, when you have a chat with the education sector, please consider the medical training institutions in matters scholarships and health. Thank you very much. We appreciate the collaboration with the county government. We not only do our practical areas at St. Mary's Mission Hospital, Mumias, but we go for our community diagnosis at Mumias level 4. We also go to CGH, and we appreciate that, and we hope to continue to work together. Thank you very much. many of us. Good. So I think you'll allow us to carry the report. When we have solutions, I can see some are short term, others medium, others long term. But I think the first one, if we resolve it fast, we should be able to assist you with all the rest. If you receive your money from anywhere, you should be able to buy equipment, be able to renovate your buildings, be able to pay your staff, you'll be able to buy medical supplies and equip the newborn unit. Yes, if we do number one, it will resolve up to number six. Number six, we can discuss once we get back to the ministry, we see if people are available. We'll see if we can set a few. But if we say you consistent, we'll be able to NHIF is a problem across all facilities, even the passport is clear. But also, sister, you don't need to wait for a very long time to put in your claims. Your claims should be done as soon as they can be done. Even if you have been processed for 2 weeks, claim, so that we are not accumulating. But we are putting in systems. With the digital system, it should be much, much easier for claims to be processed. Because we don't anticipate any manual interventions in the new system. And since we have ensured that all Kenyans are covered by insurance, we should have enough money to pay for it. I was telling people that if everyone pays up for the insurance, we have enough money to take care of Kenyans and even have some surplus. Everyone paid insurance. Right now we have a problem because with the NHIF, many people don't pay. And those who pay, somebody waits until they are told now you have diabetes, or now you have kidney problem. Then they go and then they go and pay 6,000 for NHIF, they pay for the year, and their first visit in the hospital, they spend 12,000, they have cleared everything they paid. So it becomes a continuous problem. But now we want to ensure that under the social health authority, everyone pays. For the indigents, I have seen you have listed these ones here. The government of Kenya will continue paying for them, for those who cannot afford to pay. We are going to ensure everybody is on cover. Except the change that we are saying now, everyone pays according to their income. You cannot be earning a lot of money and paying very little to your social health insurance. People who earn $1 million at the current rate, we pay 0.01%. Yet if you come to my phone, I am in so many WhatsApp groups raising money for medical care. So why would I not pay my 2.75% of my income and ensure that there's no WhatsApp group on my phone? Equally for all of you. Sisters, even if you are putting WhatsApp groups, and they don't know that you don't have an income. They don't. Immediately there's a problem, they put in a code. So we want to, that's why we brought the changes that we have brought in NHIF. With the new laws, we ensure that everybody at least is covered as a social health insurance. Those who can't pay, the government will pay for them. Those who can pay more, pay for those who cannot afford. Because only 3 million Kenyans are on payroll. 3 million only out of the over 50 million population. So we have to work around and see how do we take care of the 47 million who are not on payroll. Now we have a small delay of the court case, But once the case is determined, I've just seen a message on my phone that the case will be had on the 10th. Once it's determined and we get our orders, I only need 2 weeks for us to roll out the forms that we have. So the president has been saying, and we have already done the regulations that NHI should be reduced from a minimum of 500 a year. You know, we now people cannot pay that 300 because of the costs. Yeah, people don't know the repercussions of some of these things. We have said in those laws that we are going to pay for critical, chronic, and emergency. Now we can't pay because of the court case. It's Kenyans who are suffering really. And unfortunately, that the people who have gone to court are people who have comprehensive medical cover paid by the taxpayers. It's the irony of life in this country. So I hope, Father, you pray for also pray for the judges that they see reason that all Kenyans deserve to have a medical insurance. Yeah, so that they make them a good determination. Beginning this once they do, they don't give me 2 weeks for talking about exam to start rolling out our reform check. And everybody's going to benefit, including you.
Yes.